Welcome you all to this hall, 8 o'clock in the morning, for the instruction course on femtolaser assisted cataract surgery. We have named it the A to Z of FLACS, but obviously A to Z of FLACS is something we cannot cover in 90 minutes time. However, we have segmented this to the best of our abilities, and we will discuss about the machines and the platforms, but that comes a little later. We have the different cataract scenarios and how the femto laser technology addresses each one of them. To to begin with, we have a slight change in the schedule. We will have Dr. R. Krishna Prasad speaking on flax in soft to moderate cataracts. That would be the first talk that we'll take, and followed by the other speakers who are Dr. Supriya Sri Ganesh, Dr. Ghazal Patnaik, Dr. Arup Bhaumik, and myself, who will come in the end to discuss about the different platforms that are there in the industry at the moment and how do they work, how does laser work, how does it generate the pulses, and what do different terminologies mean. So, getting off without wasting any further time, Dr. Krishna Prasad, right in front of you before the podium, sir. Here's your audience. You can start your talk now.
Thanks, Dr. Anurag. So, good morning, and it's a very interesting compilation of videos on a very important topic of femtosecond laser-assisted cataract surgery. Well, people who have it vouch by it, and people who do not use it always have a list of objections to this adoption of this technology. So I think it's A to Z probably covers most of the things. I hope that we will, at the end of this IC, will be able to really drive home some very important points in the technology advancement. So I'll be speaking on the how do you manage soft cataracts as well as cataracts of moderate hardness. So this is a case where you can actually see that the capsule is already free floating. So just to take a word on this, there are a lot of naysayers and detractors. We are all surgically very competent. We can do a rexis in almost all the times, and just to do a rexis, just to cut a nucleus, why do you spend money on this machine, and you have to spend on the consumables, which is pretty pricey. Patient has to go to another setup, and there's an extra time that is taken. So that obviously there are many obvious objections to this. But look at this. It was a free floating. The rexis was already made, a 5 millimeter perfectly centered, very circular rexis, which is not manually possible, even though you can come close to it. But the point is not about how we can make it in. I am a very good surgeon if I say I have only 0.1% complications of my rexis. But for that one patient out of 1,000 patients of mine, it's a 100% thing. So it's basically as we move forward, okay, not taking our individual cases in consideration. If you take the majority of surgeons, see our patient, look at the patient perspective, they end up with sometimes people with lesser surgical proficiency, or the clinical situations probably more demanding. They may not have the enough expertise to handle such situations. Then for the patient, a bit of automation, a bit of, if you can take the human errors out of this, so then that can make up for the incompetence or maybe a chance event of things going wrong. So this is where the FLACS kicks in here. So the rexis is already made, so which makes my job simpler, and I am now trying to separate the nucleus and the epinucleus from the thing. So basically is already some amount of hydro delineation or dissection that has happened. The carbon dioxide bubbles have already created some kind of a loosening, and now you already have a nucleus which is cut into 6 pieces. This is what I use the chop, I use the Lens 6 platform. Now I've also started using the Zima platform. So this is where it's already pre-cut. So it's just like how you separate your pieces of a pizza, which is looks little daunting for beginners, but probably when you start eating more pizzas, you will understand it is not that difficult. At the same time, without cutting a pizza into 6, it's very difficult to eat a pizza. So once you separate them, once you just need to separate, you don't need to really do anything much. It's already cut. You just need to separate them so that the pieces it becomes so simple, so easy. Because nucleotomy, how much ever edited videos we show in the conferences, that we marvel at those nucleotomy techniques which happens in the jiffy. But at the same time, there are a lot of videos that you can actually show where you get into trouble, at least in beginners trying to do the nucleotomy in all different types of cases. So this takes this error out of it. This take this chance events out of this, so that you can create a safe a surgical milieu. You can really offer that justice, or what I should say, an equal level playing ground for all surgeons, so that you can have a much safer surgery. So this is where it's slightly a harder cataract, where you can see the nucleus is. So here this delineation, if you can slightly increase the energy in your energy settings, you can still get a very good cut. So basically there's already a default energy setting in the machine. For a soft cat, you can actually go down. You don't have to really overexpend the energy. For a harder cataract, you can definitely have that option, just like you increase the phaco power or the OSIL percentage. Similarly, you can also increase this your femtosecond laser settings and use this. So this is a soft cataract. See, this is just a demonstration. You can have different ways of nucleotomy. What I showed was a 6 pizza cut, which we call it as chop in Lensex. This is where a frag, where you make multiple cubes. Okay, just I use the word pizza. I can use probably a dokla here, a mini cubes of your whatever dimension that you want in 3 dimensions. So you have small cubes, which basically softens the entire nucleus. Well, let me tell you, for beginners, a soft cataract is not easy on a lens, on a FLACS platform. It is actually a moderate hardness cataract. Is a very ideal situation where it's brittle and it really gets cut and very easy to delineate the pieces. A very soft cataract, you should make sure that you reduce the energy. At the same time, preferably make a chop rather than a frag for beginners, so that you can actually easy to pick those soft pieces. Because if it's a very soft cataract, if you can use this frag or even chub, you can actually, since it is already cut, the whole nucleus can be sucked out. You can even create something like a phaco aspiration situation where the whole nucleus, because of this pneumodissection and delineation, as well as your additional hydro procedures, the whole thing becomes mushy soft and can be sucked out very easily. So this is a smaller pupil. I think we have a talk on this. What I'm trying to just show is that you can actually catch each piece, bring it to the center. The only problem in a soft cataract is the rexis size, which normally, the pupil size determines the rexis size here. You cannot really have a way of expanding the pupil and doing a femto in most cases. So obviously you are limited by the rexis size, but still even a 4.5 millimeter rexis is good enough in such cases where you can really bring the pieces to the center, because you don't have to really go to the end and try to chop. The complication rates come down very drastically because you have already had cut pieces there. You just need to kind of latch onto it, bring it to the center in the safe zone, and emulsify it further. So but at the same time, I just want to show, to make my point. See, this is a case which I have made my fellow to operate. Of course, not just because of this IC, it just happened. I had done the Lensex. So this is how you take this learning curve out of this. This newbie surgeon is operating on where I've made a 6 cuts in the nucleus. It's a pretty good case for a beginner anyway. So this is where and it's not very difficult for a new surgeon to just, so this is what I'm saying. It takes the difficulties for a person. If he's trying to make a trench and make a soft, stop or chop or a direct chop, obviously it would create some new challenges for him. See, he that he's very tentative, very provisional, and his moves are not very confident. But nevertheless, you can still see that how he's doing his job well. You can see the little tremors on the left hand. So once he is able to pick it up, and everything falls apart. The pieces start disintegrating because there is a space for the fragments to fall apart. So this is almost an unedited video of a new surgeon. I mean, doing it for the first time. So this is what I really want to say, that from the patient perspective, obviously the human errors are much more out of the equation. So basically, a moderate nuclear hardness is an ideal situation for beginners at least. See, the idea is that once you normally there is a small fear in the beginners that if you do a too much of hydro dissection or a vigorous hydro dissection, because already the kind of lens is, little become saturated with those bubbles, there's a possibility of a PC rupture or PC tear. I think we can ask other panelists, even Dr. Sri Ganesh is here, we can probably discuss this. So there is always some kind of a less effort in trying to mobilize the nucleus, or we don't get a free rotation. People don't really rotate. But I feel that unless you get a good rotation, okay, you should not continue, because it may really create some problems on the way. And the depth of nucleotomy, you can actually preset the depth depending upon the lens thickness. So you can really go to the entire, believing that the minimum required protective margin from the posterior capsule, the entire nucleotomy cut really makes jobs much simpler. And does this surgery makes surgery faster? Is it the speed that we are trying to look at, or it is the safety? I think it is probably both. Even though you spend some extra time, I mean, just before you start the surgery, okay, but keeping the advantages of safety, advantages of the repeatability or the reproducibility of the steps, and most importantly, the human error component. Okay, if you can take the human error component out of the equation, so this really makes up for whatever that extra time that you're going to spend. But at the same time, in a situations like where you have a weak zonulopathy, or it's very very difficult to do a rhexis, like if you have a dangling lens, with all your accessories and great surgical expertise, you may be able to just make a rhexis, sometimes very small, sometimes very close to the weak zonular area. So sometimes you may not have enough adequate margin of the rhexis to really put your capsular hooks. So it makes the entire job difficult, and during the process of rhexis you may damage some more zonules, which is usually the case. So since those videos are very well edited, you may not sometimes see the real story. But here it's completely human effort free. You can get your rhexis wherever you want, depending upon, you can move the entire rhexis to the actual central location of the displaced nucleus, and without causing any kind of a manual derangement of the zonules. So in special situations, obviously, FLACS really scores hands down, and should be the thing. Obviously, the technology comes with a cost, but there are definitely ways to really work on that. Thank you very much for your patient hearing. I'll be very eager to hear the other inputs from the other panelists. Welcome, Dr. Arup.
Welcome, Arupda. So for convenience, what we have done is, this is how we would be dividing the session. Dr. Krishna Prasad and the next speaker, both of them use the LensX platform majorly. Then we'll discuss about the machine platforms that are available, and then we go to the other platforms, like Dr. Arup Bhaumik, who is one of our co-instructors, uses the Catalyst, and Supriya uses the Zyma Z8. So it'll be interesting if we put it that way. Sir, just one question before I call in the next speaker. I saw that some of your videos had the 2.2 sleeve attached to the needle. Yes. Some of them had the 2.8 millimeter sleeve attached to the needle. All of them had a similar grade of nuclear sclerosis. So what do you decide that on when you're taking out FLACS? That's number one. Number two is, we know that when we fashion the corneal incisions on FLACS, the outer lip and the inner lip have different dimensions, and the inner lip is actually wider than the outer by around 0.2 millimeters. So if you are fashioning a 2.8 millimeters incision on FLACS, it'll be 3 millimeters on the internal side. So do you do that with the FLACS machine, or when you choose to do a 2.8 millimeter incision, do you go the manual way?
Second question first, that is, I don't use the I have stopped using the corneal incisions.
Okay.
So for the convenience sake, and I really did not find much, even though my cornea department people use it. I have stopped using it for my own reasons. Well, not with any specific intention. Just like I just stopped using. That will really take, lessen my time that I spend at the lens exhibition. About the sleeve size, I think Dr. Sri Ganesh is here. He was the one who made me change. Because when microcoaxial 2.2 was a big deal, and we really did for years together using that, we were very happy that we were just telling 2 millimeters, even though it was 2.2. And I really had a lot of, some kind of a pride in lessening the incision. But when I had one of his lectures where he himself shifted to 2.8, when the whole world is trying towards going to the smaller and smaller incisions, which was the kind of the hype, like he kind of reverted and said that it makes a big difference in the fluidics, which I went and found it for myself that my surgery is much more safer, faster, better AC depth control, just by increasing it by 0.6, which did not really make much difference in the astigmatism profile or in anything else. There was absolutely no difference in the outcome, but my surgeries were much more kind of faster, and it is it's basically a subjective thing, which I got inspired by him. So since then I've been using 2.8 sleeve, even though I use all the lenses which can go through 2.2 very comfortably. There is probably in cases where you have a small anterior segment, especially in case of some relatively micro-ophthalmic eyes, I switch to 2.2. But otherwise, in most normal routine cases, I use 2.8. Well, it's a point of individual differences, and people can probably choose what they want to do. It doesn't really make a difference in the astigmatism outcomes as per my experience.
We invite the next speaker, Dr. Ghazal Patnaik. For those of you who do not know who she is my associate working with me. She joined me after completing her fellowship at Shankar Nethralaya. An excellent ophthalmologist, very good surgeon, very proud to have her with me. And she speaks on FLACS in the presence of a small pupil. Over to you, Ghazal.
A very good morning, everyone. Thank you, Dr. Mishra, for giving me this platform, and thank you, Dr. Krishna, for laying down the groundwork for me. So before going into FLACS in small pupil, let's first understand the challenges we face for any cataract surgery in small pupil. So it begins with the first step of making a rhexis. In any small pupil, the zonules are expected to be weaker. The rhexis, there is always a chance of runaway. Also, we tend to make a smaller rhexis when the dilatation is poor. So the next thing is coming to the nucleus emulsification part, nucleus fragmentation part. In that case, as we can see here, the risk of iris damage is too high at every step. Also, getting a piece from under the iris surface, it's very risky. Also, you can catch hold of any tissue that is nearby. And by the time we reach at the cortical removal step, it's kind of a blind procedure. Any beginner will face difficulty here going down, and there chances of complications like zonule dehiscence, bag dehiscence is quite common. So in short, it revolves around rhexis formation and visualization part, which kind of decreases with every step, with every minute. Like in small pupil, nucleus fragmentation and emulsification takes the maximum time, where the fluidics as well as the side instrument damages the iris pupils, iris sphincters, and the pupil size kind of gradually decreases. So does FLACS has a role in that in small pupil? Let's understand this. So first, a normal case where you can see the pupil is well dilated, you can have a rhexis of around 5.5, and as demonstrated earlier by earlier speaker, the rhexis and the nucleotomy is done, and after that it is just a piece of cake like any other routine cases. Also here as you can see, comparison between a normal dilatation pupil where you can get a 5.5 mm of rhexis, and in little bit smaller you can get a 5.3. Similarly, if you have a much smaller pupil, you can even customize to 4.7 mm of rhexis margin, which you can see is quite well centered in an irregularly dilated pupil where you have different iris atrophic patches. After that, you just have to take out the loosened up capsule rhexis, and then the nucleus fragments as described is already softened. So you just have to take each pieces away. So here, once the docking is done in the solid lens access platform, sorry, I'm not able to move the video. Yeah, no, just
She's saying she's not able
not
to
able to
fast
speed
forward
it up. Yeah. So once it is done, you can see the parameters that is been shown. So you can customize it according to the pupil size you get. So you, if you get this type of pupil size, you can customize it to 4.7 and then lens chop what area you want to chop the lens, and then with the help of the cursor you can move the particular region where you want the laser to be emitted and the cuts to be formed, both corneal as well as the nucleus part. So here the 4.7 mm FLACS patient, as you can see, the nucleotomy part, you need not go under the iris merge. Pupil size, the dilatation of the pupil at the end of the FLACS is well maintained. The rhexis is done, and just you have to separate the lens pieces and take it out in the center and eat it up. So we did a comparison of FLACS with the conventional phaco in eyes with small pupil. So we did for a moderate grade of cataract from 2 to 3 grade LOCS3 with maximum pupil size we took as 6 millimeters, and all went the same dilatation and FLACS and the cataract removal procedure by a single ophthalmologist. All other retinal and co-ocular disorders were excluded. And we took 25 eyes of 25 patients. We did all the specular thing after the FLACS was done to understand if there is any corneal damage also after the laser emission. We took into consideration the suction on time as well as the transfer time, and we compared both the baseline parameters in both the groups. And what we found here is the endothelial cell count, the change in endothelial cell count is quite correlating with the ultrasonic time, the total phaco time and cumulative dissipated energy, which is quite higher in cases of an conventional phaco as compared to FLACS. Also, there was a case of posterior capsular rupture in the conventional group. So coming to the historical part, femto when it started, it was mainly for the Fuchs dystrophy, where it minimizes the endothelial cell loss, which was taken care as a greater importance. Also, they pointed out that it has a limited scope, especially in small pupils, and they said that FLACS will be useful in complex cases like this, and they excluded small pupils. However, if we go to the understanding pathophysiology of this technique, capsulotomy, that is centered capsular rhexis, is useful for effective lens position. It reduces rate of tilt, decentration, any optical aberration, and hence oblique astigmatism as well as higher order aberration. Lens fragmentation and liquefaction is also taken care by the FLACS because it softens the cataract and aids liquefaction more in the cube grid form of laser application as already mentioned. Endothelial cell loss as has been implicated from the beginning because it reduces the phaco energy and as well as the time and the need of the fluid. So the refractive outcome combined because of the effective lens position, the reduction in phaco energy as well as time, it increases the refractive outcome as well as the predictability because of the better wound healing as well. So in literature, as you can see, the various authors as well as the trials like FEMCAT and FAT trial, small pupil is just a part of a larger group of sample of patients. There are few case reports where they have also used this FLACS technique in cases of small pupils like 3.5 also, where they have used hooks. They have cut the extra length of the hook so that the hook does not touch the docking surface. So that is because the pupil size was 3.5 mm. Also there was a technique by authors like, they also use double docking technique, but here they used malunion ring, M rings. What they did is they inserted the malunion after doing the first docking and then they carried out the nucleotomy part. A similar thing was done by a German group of people where they did this 3-step in 40 patients and they got a very good result. So pupil size alteration during femto is very minimal. This decrease is mainly correlated with the length of time it took to use the laser to fragment the lens and the distance between the pupil margin and the capsulotomy, which can very well be manipulated as per the customized as per the individual need. Thank you.
Just a point for discussion, like normally after we do the nucleotomy or whatever, the lens X procedure, what is the usual time we mean before which we need to shift and start the case? Does it really, for example, for some reason we delayed for a half an hour or 45 minutes?
Yes, sir. That's why I mentioned that we have calculated the transfer time also. And here for the study, the transfer time included the time we took for the examination for specular as well as anterior. So if we reduce that time, it's only like 10 minutes. If you just have to, one will be doing femto, other will be doing OT, so it will be very fast. It won't eat up much of your time, OT time.
And what about the inflammation part? Sometimes it's not just the pupil, sometimes the intraocular pressure goes up, sometimes the eyes become little, they start developing some kind of a discomfort if there's too much of time for some reason.
Yes.
So I think it's not just the pupil, it is also the patient.
So that's why I discussed about this pupil size alteration. If the more the iris is touched upon, more the iris is damaged or irritated, cytokines are like produced more. The inflammatory cytokines are released more by the iris tissues. So if you do the femto and immediately transfer the patient to the OT, it hardly takes 10 minutes. In that 10 minutes, the pupil size is maintained, cytokine level won't rise to that level that the patient will feel any pain.
I can see a nod of head from the master here. Can we get a hand microphone?
Okay, first we'll ask him, what is your normal routine? What is the standard plan for the transfer? And if you're using Zimmer, is it done in the same theater?
He has it in the same OT actually.
3 minutes?
Only 3 minutes? Same theater.
It's
Everything prepare before LASIK docking and just move the patient to this.
So you have the FLACS machine inside the OT. All right.
we use
Another thing, if you permit me, our average is 100 cases per month. So what
100 FLACS per month.
see, small pupils are regular and they insist more than the wider people.
I mean the patients insist.
That's the usual case.
You try. They are force us to try. So what we do is.
And who tells them they have a small pupil?
We tell.
You do,
Is
okay.
it difficult? No, you try, sir. Why not?
Okay.
That is the tendency of our people.
Do the two stages.
No, same table. We do the side entry. Do the side entry. We put a VX ring.
And then doc.
Then down. So some cases with methyl cellulose inside, some cases we wash the methylcellulose and put the saline. BSS and which machine?
That's what my question was.
Catalyst. 2016 we purchased.
You apply the laser with the methylcellulose inside the eye?
Yeah. And you have to increase the parameters of the Rex.
That's what, I mean, that's the reason I was asking. You have to significantly increase it.
Yeah.
Yes, sir.
One of the disadvantages of FLACS is that the pupil comes down. It comes down in 30 seconds. So even if you're going to shift the patient after 3 minutes, you still have a small pupil, but the capsulotomy is already done. You can preempt this by using NSAIDs. It makes a difference if you use NSAIDs. And the discomfort is mainly because of dry eye, because you put anesthetic drops before doing the FLACS, and then sometimes the eye is kept open, or the patient has opened his eye, there's no blink reflex, eye becomes dry, and the amount of dry eye post-op is more, discomfort is more. So immediately after doing the femto, just put in some visco, close the lid, ask the patient to keep the eye closed. These are all small things, but it makes a big difference. And we have the Z8 and the Lensar in the same OT, so it takes like about less than a minute to shift them after the FLACS to the, and I do 100% FLACS. Yes, if you have a small pupil, then you can put in a Maligan ring, you can put in a BX ring, but then again, there is a risk. If you make for a Maligan ring, you have to put it through the main incision. For the BX, you can put it through the side, but if your wound construction is not very good, if you raise the pressure, there's a chance of leakage. The other thing is the visco itself. Sometimes there are some small bubbles in the visco, they block the energy. You can have tags. Putting in the ring, and then after that docking. Once you put in the ring, it kind of indents on the anterior capsule, shifts the plane so that the anterior capsule is not uniform. So you have to increase the depth, and even with that you can have tags. So it's not that you have promised the patient FLACS and you have to do a capsulotomy. If you have promised FLACS, you can do the arcuate incisions. If he has some astigmatism 0.5, 0.75, you do an arcuate incision. You can do the main incision. But you know why? If you feel that doing a manual rexus is better, putting a ring, doing a manual rexus is better, then go ahead with it. Use the femto for other steps if you promise the patient. I don't cut the nucleus because I do a direct chop. I have found that the difference, anyway, even if it cuts the nucleus, it's not going to cut it through and through. In a hard cataract, you have a plate which does not crack, the posterior epinuclear plate. So you have to go in, you have to bury, you have to chop. The amount of phaco energy difference, same energies, less than.
There is a 86% reduction of energy, but in my practice I have seen it's hardly matters 5-6%.
Plus, yeah, it's less than 5%. Plus, for very hard cataracts, I prefer to use the Maligan ring because you have a through and through cut, and there's less energy. I mean, sorry, the MyLoop, because it has a through and through cut, and you have no energy in the eye, and it does a better job. Plus, if you make a lot of incisions, the cylinder or the small cubes, the patient is unable to fix. You're not able to see the rexus margins because your red glow is distorted. You can't see the small tags, and if you kind of try to just think it's free floating and pull it, you will have a runoff. You can even have a nucleus drop if you have a runoff. So I don't like to do nucleotomies because they're like half and half. They don't really provide that much of benefit if you're doing a direct chop. If you do the softening with the small cubes in a hard cataract, then sometimes you have some of these cubes go under the iris and get stuck there, and first day you see them nicely in the antechamber, and you have to tell the patient that I'm going to take you up again.
There's something I forgot.
Yeah. So these are, yeah. So I left behind a piece of your cataract, I need to remove it. So these are all issues which are there. So you should know when to use it, when not to use it. And then if you actually do too many incisions under topical, the patient is not able to see the light properly. There's too much of scatter. They don't fix properly. So these are all issues which can be there. And the benefit is not much. You don't save on energy. For soft cataracts, yes, because for soft cataracts, those in-between cataracts, the too soft, you can aspirate. But if it's like the neither here nor there cataracts that Ron calls it, for these grade 2 plus, then you can do 4 quadrants, and then I do the visco chop technique. We have published it. I just put in viscoelastic, and then it kind of separates and splits the posterior. So you can do a one-hand technique. It's very easy to remove the nucleus.
No, just a question. Like,
Just before we proceed, I would request my co-instructor Supriya and Arupda to come in off the chairs, please.
what is the
And the reason
minimum,
why,
minimum rexis, femtorexis that you have done, like pupil, let's say 4 millimeters or 4.2 or 4.5. Will you still do a 4 millimeter rexis, do the phaco and then
you can do a double rexis, but it does not serve any purpose. So if it's an intumescent cataract, then yes, double rexis is justified. But in a regular cataract, doing a double rexis, you can as well put in a ring and then do a nice job in the first go.
That's
so
right.
Just because you have promised the patient that you will do and taken, you can do the other steps.
And in any case, I think when you are keeping any wound open, the side port or the main port, and then you are taking the patient back for docking inside the OT. It will only be possible, it's something that we only should try if it's a liquid docking mechanism like the Catalyst or the Z8. It should not be done with the Lens X because it's a solid docking, it flattens the cornea considerably, and there will be a communication for sure. So I don't think we should even think about it, we should even try it.
So in spite of all these points that were discussed, why is your practice 100% FLACS?
Yes, because what happens is we have a Lean Six Sigma project where we continuously monitor outcomes, and we looked at the FLACS and the non-FLACS groups. The difference in accuracy of refractive correction is about 8 to 10%. So 8 to 10% of patients in the FLACS group were within half a diopter, more than the non-FLACS groups. This is because, of course, you're doing a perfect capsulotomy, you get a very good centration of the lens, plus you're using your astigmatic incisions for small amounts of astigmatism, which kind of bring down the spherical equivalent. So the outcomes, yes, they are marginally better. I would say about 8 to 10% better. And it kind of, the other advantages is if you're using a femto lens like the Femtis. The Femtis lens, you need to have a femtosecond perfect rexis for fixation. So these are all some of the reasons why I prefer to use FLACS, but I use some steps, I don't use the others. And
but sir, looking at
that
your
means,
volume of practice, I don't think 10% is marginal. It would be in
yes,
absolute numbers.
yes,
it would be
it is a big number that increases patient satisfaction, because when they come for a premium surgery, you're using a premium lens, you want to be within half a diopter spherical equivalent. The multifocals and all that, they work best if you're within half a diopter spherical equivalent.
Right.
So your FLACS, preferring FLACS, what is the main reason? The main reason is the rexis.
Yeah, the main reason I use it is the rexis, and sometimes the astigmatic.
Do you use a corneal incision with the FLACS?
Corneal incisions, I have tried. With the other platforms, it's terrible. You have to dissect it. There's not much of advantage. You have to be clear corneal. With the Z8, you can be limbal because it has a corneal module. You can do keratoplasty, you can do clear and all that. So the incisions are just like a blade. You can just go in with your cannula. You don't have to actually dissect and open the incisions. So with the Z8, yes, sometimes I use the incisions, but again, the incisions do not make that much of a difference when you compare it with your blade. If your blade is good, I use money blade, so it's almost the same. I look at it on the intraop OCT. The wound configuration also is pretty good. So, but probably the rexis makes a big difference. Nucleotomy again doesn't make a very big difference. In soft cataracts, yes, for the visco chop technique, it makes a difference.
So I have one question to you. You are shifted to 100% FLACS. So it's a FLACS and surgery by the same surgeon. It's a two surgeon combination.
It's like yes, the optom, the
because
laser tech.
as your volume, if
so
you
that is what I wanted to bring out as a point. You listen to the flow chart of his OT. It'll be very interesting.
So
Yes,
I have three tables which kind of move. So I have the laser, and then I have the 3D microscope I'm operating. The laser is done by the laser tech, but it is verified and finally approved by my fellow.
Okay.
Okay. So then the laser is done, standard fixed parameters. If I want to change anything, I've already instructed it pre-op, is done. Then the preparation happens. There's the OT assistant who prepares, and then it comes to me. So I'm able to do about 15 cases an hour. In fact, I can show you in time lapse also how it happens. FLACS does not
We
actually
have
reduce
been
the time.
tired of clapping for him, sir.
No, it does not actually reduce your time. It can improve efficiency, and then you have a perfect rexis most of the times. But there are some conditions where you have to be very careful. You know, when there are any corneal scars, post-RK, corneal scars. If you have had silicone oil post-vitrectomy, you have some of those small bubbles come in, they can block. Gutte, now sometimes you take a case of Fuchs saying that, okay, the amount of energy you use is less if you do nucleotomy. But the gutte itself, if they're big, they actually block the laser, and then you don't get a good rexis. So you should be aware of all these situations and the problems that can happen and how to overcome it.
And in case of, in the presence of corneal gutte, I believe the threshold we have for the energy use actually should come down significantly, because the laser energy, when it is being delivered into the eye, the endothelium does not have a protection of viscoelastic. So that's something we have to keep in mind. So the threshold, the energy level where we wish to be, has to come down ultimately. So that's something we need to calculate.
And it takes much more energy to do the nucleotomy than the capsulotomy.
Excellent discussion. Thank you so much for waking us all up. Right, so we'll take it forward, and there's a reason why Dr. Sri Ganesh can afford to keep both the machines in the same motif. We'll talk about that in this segment. So the evolution is something that we will discuss eventually. The first thing is, if there are so many points that just came up, it doesn't offer a significant advantage over a good cataract or a reasonably good cataract surgeon over phaco, then why do we have it at all? We have it for different people, might have different reasons, but I had, when I purchased the machine around 7 years back, I did it because I wanted to have my share of the educated technocrats fun. That's all I want. I love working with machines. I love understanding them. And that's the reason why I had it in place at the first place. So this is how the laser concept evolved in the world. The first laser was built by, you all know this, Theodor Maiman, using a ruby crystal medium. That was way back in 1960. And the first clinical ophthalmic use came in 63. The YAG actually was a landmark discovery, and that invention, sorry, and that's from where it took a huge leap. That came in 71. Excimer was developed by Trockel. Femto laser was approved by the US FDA as late as 2010. So that's actually a significant starting point of the laser technology coming into the aid of cataract surgery in particular. But whatever we do, we cannot forget this gentleman called Mr. Theodor Maiman, who actually gave us the gift of this concept way back. These are certain terms that are applied to lasers. One is frequency. Frequency is the number of laser shots fired in 1 second. It determines the speed of laser. The LensX, for example, operates within 50 to 150 kHz. The Catalyst always operates under 100 kHz. So technically speaking, the Catalyst is a faster machine than the LensX. That's the reason why it performs the capsulotomy way faster than the LensX does. I'm not talking about the overall surgical or procedural time, but the capsulotomy is way faster. Wavelength, as we know, with any light, it's the distance between two successive crests or troughs in a sinusoidal wave. This determines the type of laser, and femto is an infrared laser operating in the 1030 nanometer range. Pulse width is the laser exposure time for the targeted tissue. It's either 10 to the power minus 9 for a nano, 10 to the power minus 15 is femto, and 10 to the power minus 12 is pico. Out of the platforms that we have in the industry, the LensR is actually a picosecond laser. It's not a femtosecond laser, strictly speaking, but the other platforms are all femtosecond. Energy, the amount of energy required to create an effective action, which is for the LensX around 3 to 15, and most of the platforms operate within that energy range of 3 to 15 microjoules. This is where the LensX laser and all the lasers virtually stand, 1030 nanometers. We know that the visible spectrum lies within 400 to 700. So this lies on the infrared segment, and these are the invisible segments of light. Let's look at the science of the lasers, femtosecond lasers. As we discussed, they have a wavelength of 1030. It works on the principle of photo disruption. Now, laser has got three basic properties. One is thermal interaction, which is heating, basically coagulation, carbonization or vaporization, and it produces huge collateral damage to the surrounding tissues. So that's something we cannot use for cataract surgery. The second is photoablation, which is basically molecule bond breaking. So this is what we do in refractive procedures, predictable tissue removal and low influence on the surrounding tissue. The least amount of effect on the surrounding tissue comes from this photo disruption principle, which is basically ionization of atoms, formation of a shock wave, and that's what disrupts the tissue and causes a cleavage in the dense tissues such as the nucleus, and it has very low influence for surrounding tissue. This is the laser engine. It has one of the components is the oscillator, which produces the desired laser pulse. The next component is a stretcher. It stretches the wave, amplifies it, and compresses into a narrow beam. That's the second component. Finally, there comes the energy section, which is responsible for delivery of the energy through the desired pathway. A thermal shield is there, obviously, because it produces a lot of heat energy, which can direct the sensitive components of the machine itself. So there is a thermal shield. And this is the crystal that is used. It's called the terbium doped potassium yttrium tungstate. Every time it has to be read from the slide. You cannot remember this is a real tongue twister. Now we go to the comparative account of the platforms. The first comparison is the reason why Dr. Sri Ganesh has it in the same OT. The area the machine occupies is the least with the Zymer Z8. It's massive with both Catalyst and Lensex. And Lensex perhaps is a bigger machine than even the Catalyst is. But the Z8 is actually the smallest of them. There's a reason why you can keep it inside the OT. So the footprint is actually not the carbon footprint. The footprint of the machine is the least with the Zymer Z8. But this is not what we are discussing. Let's talk about the OCT first. How is the OCT taken? The Lensex, what it does is it has a real-time HD OCT imagery as you go down to dock the machine. Okay. For the capsule, what it does is it takes a ribbon-shaped cut of the whole capsule at the plane where the capsulotomy is performed, which is a little below the most convex region, and then it stretches it out. So even if while docking the eye has moved a little, this is how the shape comes in, an S or sinusoidal shape. Then you can move your cursors to adjust to the highest and the lowest point. So even if there is a subluxation of kind or there is a tilt of the head, it kind of adjusts for that. And you can see that in the real-time live OCT imagery. So that's what the Lensex does. The Catalyst uses multiple line scans across the eye and then combines them to process to locate the angle corresponding to the relative maximal tilt. So it also has a tilt adjustment. And then there are sagittal and axial scans as well. The sagittal scans and the axial scans, which define the capsular boundary. But it does not give you a line. This is how the imagery comes in, and you have to adjust the capsulotomy according to that. The details about the Zymer Z8's OCT is not available to me in any case, but what I have understood is it does not have a video monitor which will show you the real-time docking, but it does show close to what the Catalyst imagery shows, and then you can set the boundaries of where you want to have the capsulotomy. The Catalyst and the Lensex have, the Catalyst has the laser gantry which is fixed. So if you want to move the head up or down, it has to be done by the movable bed. The Lensex laser gantry moves. So it has a variable numerical aperture. You can dock the patient and then the laser head focuses on one tissue like the capsule, withdraws and focuses on the cornea, goes deep and focuses on the nucleus, which is something the Catalyst cannot do because it doesn't have a movable laser gantry. The Z8 has a variable numerical aperture, but it's there in the handpiece. It's not on the laser gantry. It's there in the handpiece. So the numerical aperture moves, but the movement or the threshold of movement is slightly less than what the Lensex can do because obviously the whole machine, the whole gantry is moving. It's actually more.
You can go down up to the poster capsule also.
Here also you can go down to the poster capsule.
Yeah, so it's quite a bit, the range.
No, but
You can do poster capsulotomy.
I don't know, sir. When I read the patent papers, this is what it shows. The laser spot, in case of a Lensex, is actually optimized for the capsule. However, because of the movable gantry, the focus can be on the capsule, can be on the cornea, and can be on the nucleus. This is where the catalyst stands. It focuses on the capsule. It is not optimized, so it goes up, under delivers for the cornea, so the corneal incisions are not that good, and the nucleus, it goes down to produce deeper cuts. With the Z8, the focus is actually on the cornea, so the corneal incisions are the best with the Z8 amongst these three platforms. Although the laser optimization, the focus is, because of the limitation in the movement, the focus is not much, the optimization is very good. So the Z8 also produces excellent capsulotomies and excellent nucleotomies because the optimization is very good. What's even more interesting to note is the lensex and catalyst have spot size like these, and the tissue bridge between them is quite a bit. So you really have to mechanically open them, the corneal incisions in particular. But the Z8 has laser spots very small, and the bridges are absolutely non-existent, almost non-existent. So they open in a jiffy. But the disadvantage with that is, once you have docked and the corneal, the tissue bridges are not there, the corneal incision is almost free flowing, it establishes a communicating channel, which is why, I don't know whether Sir has it for that purpose, but which is why it is a good idea to keep the Z8 in a sterile environment inside the OT, because you can have communications before even the patient is transferred to the OT table, the phaco table, right? So nucleotomy patterns, all of them offer us this, these choices. You can chop, you can cylinder, you can frag, you can honeycomb. So all of them have, we just have to choose which nucleus requires what for the optimal balance between the energy used for the purpose and the result that the outcome that we wish on the other side. So that's all for the platforms. Thank you so much for the patient listening. Yes, sir.
The difference in the capsulotomy is also there, because if you look at the Z8 capsulotomies, they have done ultramicroscopic studies also, where you can see that the edge is quite pristine because of the overlapping, very small overlapping spots.
Yes.
You don't have that postage stamp kind of a edge which you get with the other platforms. Then the chance of having bridges and runoff is more. With the Z8, it's almost like doing it with a needle.
And it's actually if your tissue is like this, both the Z8 and lensex, what they do is they run it repeatedly so that the tissue bridge is minimal. The catalyst actually lags behind in that because it's a fast machine, so the tissue bridge is likely to be less, and you could have microtags. It's not visible under the microscope, of course, only on electron microscope.
Microtags in the catalyst is very common, very common. Almost, I think it is a 50% cases there is a microtag.
In fact, I had a catalyst. We got the first catalyst in India, 2012, and I gave it up because there were no improvements. There was nothing that the company had done after J&J took it over. Alcon has bought over Lensar.
Yeah.
So Lensar
That was big news, actually. That was big news.
No, since the Rexis is a very important outcome of this usage of FLACS, I think we need to work on, discuss a little more on this, like how to get the best Rexis without these micro tags or peripheral runoffs. Is it the delta that you have to adjust very meticulously in each case that really ensures a perfect Rexis, or is it some kind of a variation in the energy delivery, or is it the type of capsule that kind of have a different reactions to it?
See, it is a pattern also. With overlapping spots, you get less amount of tags. The other thing is, if there's a shift in the plane of the anterior capsule, then you can have tags.
Delta that if you adjust.
Yeah, that delta is normally at 400 microns. But you can even increase it to 1000 microns. We did a study also in intumescent cataracts.
Yeah.
Even if you increase it to 1000 microns, the tags are less, but still you get tags. Because what happens is, when the lens is under pressure, and once you make, it starts making the cut, the plane shifts because the the lens material comes up, and then you have tags. So that's why for a intumescent cataract, always stain with trypan blue and use a forceps, look at the edge and then peel off the rexes. Otherwise, if you think, you assume it's free floating and you go in.
Not only the shift, it's even that white cortex, liquefied cortex, which actually makes the whole thing muddy.
It can block the laser.
It can block the laser.
That is liquefied, but in intumescent, if it's like a Morgagnian or something like that, then the fluid comes out, then it becomes murky, then the laser will not penetrate.
And as Dr. Ravi Kumar Reddy said, they were the cases who will agree for lenses more than the routine ones.
Particularly the margin, that the delta you have for the inferior laser should be more, because the capsule tends to fall back the moment the fluid starts leaking. We'll discuss loads of that, but for the moment we come to the only what would I say, the holy grail of FLACS, the cases where the FLACS is of absolute paramount use should you have the machine with you, the posterior polar cataracts. And to speak about it, none other than Dr. Supriya Sriganesh is here. Supriya, over to you.
Thank you, Anurag sir, for having me present on this prestigious platform. I'm glad to be here, and the discussions have been so interesting. This is one of the scenarios in which having the machine feels like an excellent investment. This is the polar cataract, especially with a PC dehiscence. So FLACS and posteropolar cataracts. So let's just talk about PPCs. We know that they're a type of developmental cataracts with a very distinct morphology, characterized by multiple concentric layers with a distinct onion peel appearance or discoid opacity, and this is how you see the posteropolar cataract with a pre-existing dehiscence. You have this particular shape, these two linear lines, when you know that there's a pre-existing dehiscence. There is the Daljit Singh classification of posteropolar cataracts, which makes it easy to clinically identify that, especially when you see these white dense spots, it's a diagnostic sign, or the Daljit Singh sign, of posterior capsule rupture or extreme thinning with posteropolar cataracts. So it's very important to see this sign. Now, generally the incidence of PCR in routine cataract surgery is less than 1%, but with PPCs it ranges from 14 to as high as 12.6%. So that's a huge percentage of eyes that can have complications in your cataract surgery. Now, the surgical challenges, as we know, is the adherence of lenticular opacity to the thin and fragile posterior capsule, high risk of PCR during the surgery, hydrodissection is always avoided, and nuclear rotation is contraindicated. So all these things make surgery very, very challenging, and these patients are often young patients who want spectacle independence. So how do you deal with these patients, and how does FLACS come into play? Now, we know that Sir has already discussed the technology. I won't go into the details. It ionizes the tissue by producing photo disruption, basically. And the advantages of FLACS, as we've discussed, is a precise, accurate, reproducible result in regular cataracts, but also makes it much safer for posteropolar cataracts. You get a capsulorhexis, which is round, continuous, circular, which is the most important step in PPCs. It helps you also with the lens fragmentation, and as a note, AIOS-OCT can really also help you visualize the PC properly. So just a note on AIOS-OCT, in our practice we always use the AIOS-OCT preoperatively to check whether there is a PC dehiscence, but for all PPCs we advise FLACS preoperatively. Now, this is very interesting actually. One of the first case series which evaluated efficacy of FLACS in PPCs, Adler and Donaldson, they actually said that FLACS resulted in PCR in 2 patients with bilateral PPC, whereas conventional phaco did not in the fellow eye. And they suggested that conventional phaco is actually the preferred approach in PPC. And in that study, they used the catalyst, and they had adjusted for a 500 micron safety zone from the posterior capsule. But the authors opted to perform hydrodissection during FLACS. So you cannot do a hydrodissection even if you're doing FLACS. It's very important that you avoid hydrodissection in FLACS, and then further studies showed, Dr. Vasavda et al. Showed the technique of femtodelineation to create multiple demarcated layers or cylindrical layers to remove the endonucleus before reaching the posteropolar cataract. And in all the further studies, hydrodelineation was done even when FLACS was used. Dr. Titya Mahipal described the block-by-block emulsification, which is a preferred technique which I have also done recently, which is very easy to core out the cataract with these cylindrical pieces. Dr. Mahipal et al. Also have used the catalyst system, and they have an offset of 1000 microns from the posterior capsule to enable better penetration. So now this is a video of mine showing how exactly to make your FLACS settings for PPC. So you see here, this is the pattern that we choose, the cylinders with the pie cuts. So you have a 2 or 3 plane chop. I selected a 3 plane chop with pie cuts, and select medium power. This is the lens AR system. We have the Z8, the lens AR, and we also previously had the catalyst system. This is the dice module, but I prefer the cylinder with pie cuts. So this is how you select all your settings. You can also have a posterior offset. Here you see the posterior clearance is 1 mm, that is 1000 microns from the posterior capsule. This is very important to keep an offset, and then you save all your changes, and this is what the docking looks like. Like sir said, it's a flat dock. So here, once the docking is done, you get Scheimpflug images. Scheimpflug camera scans the eye, and you get images when the capsulotomy is being done. And here you can see the pattern. So you see these 3 pie cuts along with cylindrical cuts. So this is the capsulotomy being made, and this is how the fragmentation is done. And the posterior capsule from 1000 microns is completely avoided. Now during the surgery, again, we don't use the femto for the clear corneal incisions because it's much more efficient with the blades, and just remove it using, here a hydrodelineation is done. You see these bubbles are released. It's very important for the bubbles to be released, like KP sir was saying, because this itself can cause a high intralenticular pressure. Now here, see how I'm able to easily core out piece by piece by piece the central endonucleus. After doing the hydrodelineation, the entire endonucleus you don't need to chop. Usually without the FLACS, after hydrodelineation, you need to go chop the nucleus. That again causes more movement and stress on the bags. But these small pieces, you can even use the chopper or the dialer to kind of manipulate the pieces to come into the probe and slowly bring the pieces out without any manipulation of the cortical layer or the epinuclear layer as such. And here you get a good removal. So it's always important to inject viscoelastic while removing the probe, as we all know. Here I'm doing a viscodelineation technique while just gently trying to nudge away the epinuclear plate using visco, and then it very easily comes out. And once the epinucleus is removed, I thought this was actually a PC rupture because it had that classical shape, but it was just the cortex. So in such a case, in this particular case, I did not have a PC rupture. I was able to easily remove the cortex with bimanual IA and use a lens. But you see a beautiful capsulotomy and how easy the surgery is and stress-free for the surgeon when you have this technology with you. And again, it's very important, even if there is no PC dehiscence, to always use viscoelastic while coming out of the eye, because you're avoiding those AC fluctuations which can anyway cause, the PC is quite thin even if there is no dehiscence. So always use the visco, stabilize the AC, and then remove your instruments. I'm able to implant a premium IOL, a toric IOL in a case of PPC because this again was a young patient and who desired spectacle independence, at least for distance. So we're able to give our patients good results even in complex cases. So now this was an older video of Dr. Ganesh. This is when we had the catalyst system. So this is what the catalyst system looks like, and you see the offset from the posterior capsule. You can see here there is a clear pre-existing dehiscence. So the OCT shows you the pre-existing dehiscence. You make the capsulotomy and the nucleotomy here, and like we were discussing, these kind of cuts, the disadvantage is that the patient fixation is reduced. So on table you can give a subtenon block after doing these cases, after doing the FLACS for these cases, because the fixation also really matters in these patients. Now you can see here that removing the endonucleus is easy, but you're not always as lucky as getting away with an intact posterior capsule, because you see that in this patient there was a pre-existing dehiscence. So when that does happen, at least you're sure not to have a nucleus drop. You do have to do a limited anterior vitrectomy and manage the case this way. But even in case you need to implant a 3-piece lens, you have a perfect capsulotomy that you can implant the 3-piece lens in the sulcus and do a good optic capture. So after carefully removing all the cortical matter, 3-piece lens is implanted, and you can do an optic capture and have a good result even in patients with pre-existing dehiscence. That's a stable lens. Now, in the past, for pre-existing dehiscence patients, we were not able to offer the option of spectacle independence. But today we have excellent lenses like anterior capsulotomy fixated lenses, where we actually are able to offer spectacle independence for patients with this kind of picture. So you see here there is a pre-existing dehiscence. The patient wants a trifocal lens, they want spectacle independence. So here you can just see that a good hydrodelineation is done. You can see here only the capsulotomy is done using the femto. Nucleotomy is not done because it's a very soft nucleus, and it's just very easily aspirated with the phaco probe. And this is Dr. Ganesha's case, and you see here that he's just using the coaxial IA to very easily just remove the epinucleus as well. And to remove the PPC part, he is using a bimanual IA, because in these cases you get much better control by using a bimanual IA. You see that typical characteristic pre-existing dehiscence there, but the beauty of this is that there is no vitreous loss. Even if there is vitreous loss, you can do a limited anterior vitrectomy. The lens that is used here is the Femtis M Plus lens. So this lens is actually an anterior capsule fixated lens with 4 haptics. You see the clip there where you can actually clip it onto the anterior capsule. You inject the lens into the bag and you clip those 2 haptics onto the anterior capsule. It's a segmental varifocal lens which gives spectacle independence. So this, even though it's a plus 15 diopter lens, it's a young myope with a posterior polar cataract, we were actually able to give this patient uncorrected 6x6 and N6 vision in both eyes in spite of the pre-existing dehiscence. So the technology today actually allows us to give patients this kind of result. So in both eyes, this was the post-operative images. You can see in the left eye, it's a toric IOL as well, toric multifocal, and there is a PC dehiscence. So complex cases like this, we can still have excellent results by using FLACS in combination with these kind of lenses. And to conclude, I would like to say always approach a PPC assuming that there is a PC dehiscence. Advise FLACS for all your PPC patients. It's a much safer way to go. A gentle hydrodelineation is required. Just because you're doing FLACS, it doesn't mean you can do a hydrodissection. And it's shown excellent results in cases of PPC, making the surgery much safer and easier. And of course, a preoperative ASOCT and UBM imaging is always helpful. Thank you so much for your patient listening.
Invigorating, Supriya. Thank you so much for that wonderful presentation. We will take up maybe 1 or 2 questions at the end of the last talk. We've covered almost everything. We've covered small pupils, we've covered the machines, we've covered the soft to medium cataracts. The only thing that's left is obviously there's something that we need to cap the FLACS session with, and that's the hard cataract. To speak about it, somebody who doesn't actually need even a phaco machine to do a hard cataracts, people say that at the sight of him, the hard cataracts dissolve. So, introducing you to Dr. Arup Bhaumik from the Shai Hospitals, Barakpur, West Bengal, to speak on FLACS in hard cataracts. Over to you, Arupda.
Good morning. Thank you, Dr. Anurag, for including me this IC. So my topic is a FLACS in hard cataract. So honestly, in my hospital, at least 27 doctors has access to the catalyst system. We have 2 catalyst system in a different hospital. So I take a survey of the 27 doctor. How many of them are like to use a FLACS in cases of very hard cataract, Brunson cataract. And surprisingly, me and one of them is a raise our hand, and other 25 doctors are discarded FLACS in because of some issue they told, and they told they don't mind to do the Rexis part, but they don't want to any nucleotomy in a hard cataract. These are the consensus in my hospital. I'll keep this discussion open. So, what are the I have hurdles? It's in hard cataract is a thick, large, difficult to crack the posterior plate, increase phaco energy time, increase phaco time. The why I should prefer FLACS? It is a reduced energy. It is easy chopping and posterior plate management. So, if you go to the, I have borrowed some slide from the catalyst. So, they are advisable corneal incision, fragmentation and capsulotomy. And to be frank, I am using only capsulotomy and fragmentation in few cases, sometimes only capsulotomy, and I don't use any corneal incision in case of catalyst system, because it is not opened very easily in catalyst system. So, as per their data, this effective phaco time is reduced by 86%, and this is actually the meat. It is not a actual data in my hand. The main reason why the 25 doctor, though they have access to catalytic system, don't prefer to do the FLACS in the hard cataract because of the small axis. Because we know that all the system, LensX system and the catalyst system, and the size of the rexis increase over time. So you have to keep your femtorexis at least 4.8 or 4.9 to take a age over the optic size. So you cannot do the more than 5 millimeters. So it will increase over the size. So it is sometimes difficult to do the phaco emulsification in a hard cataract in a small rexis. And they claim that it's a very difficult to do a chop in the small rexis, because they used to do a big bowel in deep debulking, which is the area is much bigger, and so it is very difficult to do in a hard cataract, and it is not easy, even not very easy. It's as much as the manual phaco to crack the posterior plate. They don't have any advantage in a very thick cataract. And central softening, that is a cube formation, it's create more difficult to hold the nucleus, hard nucleus. So the 25 out of 27 doctors quit from this survey to do the very hard cataract. So this is my initial case. We bought this catalyst system 5 years back. This is the 6 quadrant, and I have a that time I do the direct chopping or the big debulking. So I see that the same kind of difficulty, and this not creating any kind of advantage to me to do the hard cataract. Even I did the 6 pieces. So it takes almost same time, and when I do the normal phaco emulsification, so I faced a lot of difficulty to do the posterior plate. So at that time I saw what is the advantage of phaco, and probably the most of my colleagues are still this phase. They are doing either direct chop or central large debulking to do the managing the hard cataract. So I just changed my phaco emulsification technique in case of hard cataract. And what is that? I did deep debulking in the central 2 millimeter only, no softening. I do the only simple, that's I presented one paper, the L tip, which actually drill the nucleus, core of the nucleus, and I started doing them. Then it is really advantageous for me in a hard cataract. I can able to crack the posterior plate in very easily when I did central debulking, only central 2 millimeter. So in that no softening, so that I can have a great area to hold the nucleus, and I can crack the posterior plate in once go. This are my modification, little bit modification or change of technique in doing the phacoemulsification in very hard cataract. So in this is almost same cases, same hardness. It is not very hard, but with the same thing I do the central debulking, only limited to central 2 millimeter, not I extend more that, so that I can have a real mass of the nucleus, so that I can initiate my cracking or chopping that created by the femto laser. And for this time I pass the femtosecond laser 5 times or 6 times. It is actually varies, I don't use, because this is that varies from the system to system, which they actually advise you for the very hard cataract. In catalyst system I have used a 5 per system and hard cataract. So my take, this is the effective when it is maybe not effective, you don't change your technique little bit in a hard cataract, because hard cataract you are used to do normal phacoemulsification in a very big rexis. You will not phaco will not give you advantage. So keeping in the mind, if you want to do a good phacoemulsification in 4.8 rexis, which is actually 4.8 to 4.9 is the ideal in the any system of the any FLACS. So change your techniques little bit, do the central debulking related to only central 2 millimeter, and it is should be quite deep enough. Don't do any kind of softening. Is a softening, as Dr. Ganesh says, it sometimes the pieces goes, and this actually happens to me couple of, not 4-5 times. So, and I stopped doing the softening technique and cube technique and change its setting and technique little bit. Thank you so much, and I think I'll keep much time for at least 1.5 minutes for discussion.
The one essentiality that we forgot right throughout this particular IC is to ask audience for an opinion. So, Ravi sir, would you like to ask a question to either of these two, Supriya or Dr. Arup? Can we have a mic? Oh, sorry, it's there. Can you please pass it on, sir?
No, he have more answers than questions.
See, as far as the hard cataract is concerned, I put 5.1 rexis. So
5.1 in hard cataract.
Yeah.
If you have a premium lens, say multifocal, but
Even then there is a overlap. I can show my
the
slit
long
lamp
run it
pictures.
will not going to stay there.
No, it will stay.
I
It is
think,
6 mm.
So since it is actually a punctured kind of an opening in the capsule, it retracts later on. So
Yes.
even during on the table, we can see that the CCC expands a little bit.
See, I used to do the 5 millimeter,
so
and at least in my initial cases, I think 80%, 80 to 90% cases are the optics is over, the capsule is behind the 5. So then I shifted to 4.7. I think 4.8 and 4.8 is okay for me. I don't know. So Anurag, you can tell.
mine is always 4.7 actually.
7.
4.6 to 4.7. Even with manual rexes nowadays, I've come down significantly on the rexes size. Yes, sir.
So how do you select a exercise? See, my standard is 5 millimeters, okay, and most of them you have a nice overlap. When do I use a larger axis? I use a larger axis for the plate haptic lenses like the Zeiss 80 Lisa, because if you have a smaller axis and it contracts, you get a hyperopic shift, and we have seen this by about 1 year in many of the cases. So for these lenses, I keep a rexis of 5.5, and still there is a overlap, and I don't have this late refractive shift. For a poster-polar cataract, I prefer to keep it at 4.8, and even for the femtis at 4.8, because if you have a smaller rexis, it's better to do a optic capture when you put the lens in the sulcus. So this is kind of guidelines on how to, and with the lens AR for hard cataracts, it's connected to the pentacam, so it grades the nucleus, and then you can have automatic settings where it increases the energy and the pattern. We have a publication coming up on this.
Supriya, I have a question for you. You said 1000 microns is the offset that you keep for polar cat. Is it uniform, or do you select it based on the picture you get from the ASOCT preoperatively? If it's not a communicating type of a PPC, if you see clear daylight between the plaque and the posterior capsule, or if you see the continuous posterior capsule margin, would you still go ahead with that 1000 microns offset, or would you take it closer?
So that's anyway a standard setting which is there on the machine. So I don't change it.
Okay.
Some machines have anywhere between a 500 micron to a 1000 micron offset, but for PPCs, it's safer probably to keep a 1000 micron offset, especially for beginners who are starting with FLACS for PPC. But as and when you get more experienced, and you can probably customize it.
No, there's a reason why I was asking that question. If you keep the offset high, obviously you're left with a thicker epinuclear plate, and you're not doing a hydrodissection on principle. So would it not help you, because after the ball is left and you do not have a hydro to support you, you still kind of rotating it to loosen it out and excavate it out of the bag.
So the idea is not to have a nucleus drop in a pre-existing dehiscence, so you are very safe in that sense, and then you do a visco-dissection to help you remove that.
Thank you so much. You know, ladies and gentlemen, we would conclude in 10 seconds time. There was a discussion in the group last evening that we would probably be addressing to one another when this session starts at 8 o'clock in the morning. We're so thankful to you for coming up and proving all of us wrong. Thank you so much. We stand up and give you a standing ovation just for gratitude for your presence. We hope that you enjoyed the session as much as we did. Thank you so much.
Thank you.
All of us are there, huh?
Because the most of the discussion with you. Thank you, sir. Thank you.
आपका नाम क्या है?
I think we'll have to.
हमारा सेशन है ना, ये टाइमर 8 मिनट्स का है।
It's called A to Z. You are the X factor.
तो कर दो ना, ये हमारा सेशन है। 10 मिनट्स नहीं, हमने कल भी बोल दिया था आपके टीम को। You can change now. Yeah. So we have to